Good morning, good afternoon. This is Greg Cosgrove from the Pulmonary Fibrosis Foundation. I'd like to welcome everyone for the next installment of our disease education webinar series. And today's focus is really trying to organize and present some of the recent data that has come out of several what I would call very pivotal clinical trials. And we're fortunate today to have two really important leaders in the field of pulmonary fibrosis. One is Dr. Adegunsoye from the University of Chicago, and another expert in our field, and we're pleased to have her as a rheumatologist, Dr. Elizabeth Volkmann from the University of California at Los Angeles. And I'll moderate today, but we really want to share some important information, and I'd like to welcome both Dr. Adegunsoye and Dr. Volkmann to the webinar series and thank them in advance for their presentations.
Thank you for having us.
Oh, of course. And really the information that I think has really hit the space is treatments that extend beyond, or potential treatments that extend beyond idiopathic pulmonary fibrosis, but affect other individuals who have pulmonary fibrosis. And their course may be different than patients with IPF, but certainly the manifestations and the difficulties that patients have with other forms of pulmonary fibrosis, we want to pay careful attention to, so that we advocate for all individuals affected by interstitial lung disease and pulmonary fibrosis. So we'll have a discussion on Scleroderma-associated interstitial lung disease, as well as a broad group of diseases, irrespective of the underlying diagnosis, but those that are progressive in the fibrosis, whether it be RA or rheumatoid arthritis or perhaps chronic hypersensitivity. And then we'll discuss a little bit the steps forward with the registry and tools that might be helpful to gain access to novel trials in pulmonary fibrosis. And then an extension of the tremendous effort of everyone who's volunteered in the registry and great investigators, talking about the Precisions Grant that is really a tremendous collaboration that hopefully will further define the diseases that affect people with pulmonary fibrosis. And so really this slide is simply to suggest we know pulmonary fibrosis, or an analogous term, interstitial lung disease, is a very broad group of diseases that affects patients in different ways. The prototypical fibrotic lung disease is idiopathic fibrosis, and that has been a center of attention for several years. But because of advances in that field, we're now beginning to investigate treatments that have been effective in that disease and understand if they're effective in other forms of pulmonary fibrosis. And I think it's a bidirectional feedback that will help us better care for patients with all forms of pulmonary fibrosis, and specifically care for those who have different forms of pulmonary fibrosis. So it's quite a dynamic process, and so I am pleased to now introduce again Dr. Volkmann, who's going to talk to us more about Scleroderma-associated interstitial lung disease, and I really appreciate her expertise and experience as she guides us through the options that patients with that specific form of interstitial lung disease can consider. So welcome, Dr. Volkmann.
Thank you so much, Greg. Thank you for the kind introduction. And I also want to thank the Pulmonary Fibrosis Foundation for inviting me to speak. It's quite an honor as a rheumatologist to be included in this type of webinar, and also very exciting to focus specifically on systemic sclerosis, or scleroderma. You can go to the next slide. So these are my disclosures. And I wanted to review the objectives for the talk. I thought it would be good to start out and just review the current treatment options that we have for treating patients who have systemic sclerosis-related ILD, which in this talk will just be abbreviated as SSc-ILD. So we're going to review some of the evidence for why we use treatments such as cyclophosphamide, mycophenolate. I'm also going to review some of the evidence for why we sometimes use stem cell transplantation in patients with this condition. And then in addition, we're going to review new treatment options for SSc-ILD. So we're going to talk about Nintedanib and then some more experimental medications such as tocilizumab and rituximab. So in terms of treating patients with SSc-ILD, there's actually no established algorithm for when we start therapy. But there are several common reasons why practitioners would start therapy for SSc-ILD. So one of the most common is if a patient has symptoms of ILD. And the two most common symptoms of ILD in a patient with systemic sclerosis are shortness of breath and cough. But early on in the course of the ILD, patients can have very subtle symptoms. They may experience some fatigue with exercise, especially going upstairs or walking up hills, or they just may feel more tired towards the end of the day. In addition to symptoms, we often start therapy in patients when they have a decline in their lung function. So patients with scleroderma usually routinely undergo pulmonary function testing, and we look at specific parameters on their pulmonary function test. So we look at their things like forced vital capacity and their diffusing capacity for carbon monoxide. And when these start to decline, we get worried that the disease is progressing and we need to start therapy. Similarly, we look at their HRCT scans. So these are the radiographic images of their chest. And if we see that there's more evidence that there's more fibrosis, more scarring in the lung, that's another indication for considering to start treatment. Or if a patient is on treatment, we may consider changing the treatment. And then in addition, sometimes we start therapy even in patients who don't have symptoms and are not having a decline in lung function, but they may have certain risk factors that put them at heightened risk for having progression in the future. So this is one example here. This is a blood test that we do, and it's called the SCL70 antibody. And when patients have this antibody, they have a much higher risk for having progression of their lung disease. So this could be a scenario where a patient may have mild interstitial lung disease, but we know it's likely to progress, so we may start therapy sooner. Next slide. So the first drug that I wanted to go through, and this is sort of in a historical order, is cyclophosphamide. Another word for this is Cytoxan. And a lot of the evidence for why this drug is sometimes used to treat SSc-ILD comes from a study called the Scleroderma Lung Study 1. And this was a study that was actually led at UCLA where I practice, and it was conducted at 13 different centers throughout the United States. And it included 158 patients who had SSc-ILD. Half of the patients in the study received oral cyclophosphamide, and the other received placebo for 12 months. And then the primary outcome that they looked at in the study was the change in the forced vital capacity. Again, another word for this is FVC, and this was a pulmonary function test measurement. But we also looked at secondary outcomes, so the total lung capacity, the DLCO. We looked at some measures of shortness of breath, so how the patient felt and functioned. We looked at their radiographic fibrosis, and then we also looked at their skin score. Next slide, please. And what we found in terms of the primary outcome was that about half of the patients in the cyclophosphamide arm had an improvement in their FVC. So on this graph here, what you see is those patients who had an increase in their FVC, and that would indicate improvement, and then those patients who had a decrease in their FVC, and that would indicate worsening. And on the left side of this graph are the patients that received the cyclophosphamide, and on the right side are the patients that received placebo. And what you can see is 49.3% of the cyclophosphamide group had an improvement in their FVC, whereas about half had worsening. And then in contrast, in the placebo arm, only about a quarter had improvement, whereas the majority had worsening. In terms of the secondary outcomes, there were improvements in skin score in the patients who received cyclophosphamide. There were also improvements in their total lung capacity, as well as their self-reported shortness of breath, and there was even improvement in the radiographic extensive fibrosis. So this study showed us that there was a significant treatment effect, meaning that some patients derived benefit from the cyclophosphamide in terms of their pulmonary function, in terms of their radiographic fibrosis and how they felt. But obviously, not everyone experienced an improvement. Next slide, please. But what was interesting was that we followed these patients for a year after they finished the study. So remember, patients got treated with the cyclophosphamide for 1 year. But then we looked at their forced vital capacity, so their FVC on the pulmonary function testing, for a whole year after the study was over. And what you can see by this graph, if you look at the lines, so the lines with the open circle dots, those are the patients that were in the cyclophosphamide group. And the line with the closed circle dots, these are the patients in the placebo group. So you can see that over the course of about 18 months, the cyclophosphamide arm patients actually did better. Their FVC significantly improved. But when you got down to 24 months, actually there was no difference in baseline, and there was no difference between the two groups. So this showed us that 1 year of treatment with cyclophosphamide was not sufficient in terms of leading to a sustained improvement in lung function, and that other treatments were needed. And part of the reason this study was only 1 year of treatment is because cyclophosphamide can have a lot of toxicity, meaning patients can experience a lot of different side effects from this drug. And we think that the longer you take the drug, the more likely you are to experience side effects and long-term risk of getting other problems like cancers. So after this study, we thought, well, we really need better options for patients. We need options that lead to a sustained improvement in their symptoms and lung function. And we also need things that are safe to use long-term, because 1 year of treatment is probably not enough. Next slide, please. So this led to the conception and design of the Scleroderma Lung Study 2. So this was another study that was led at UCLA, and it was conducted at 14 different centers throughout the United States, and it included 142 patients with SSc-ILD. In this study, patients either received the oral cyclophosphamide for 12 months, followed by placebo for 12 months, or they received 24 months of mycophenolate. And the primary outcome was similar. So it was looking at the course of the forced vital capacity over that 2-year period, and then also looking at some other pulmonary function test parameters like the DLCO, the TLC, how patients felt in terms of their breathing and daily function, their radiographic fibrosis changes, as well as their skin score. Next slide, please. So this was the primary outcome. This was the course of the forced vital capacity over the 24 months. And the solid line are the patients that were randomized to the cyclophosphamide group, and the dotted line are patients that were randomized to mycophenolate. And you can see that both groups derived in a benefit. So there was a significant improvement in the forced vital capacity in both groups, and it actually increased. And the little stars that you see at those time points represent significant improvements from baseline. If you look at the change in the FVC, so we saw a similar figure before when we were going through Scleroderma Lung Study 1. So again, this is the change from baseline in the FVC. So if there's an increase in the FVC, that indicates improvement. And if there's a decrease in the FVC, that indicates worsening. And you can see that for both groups, so 65% of the cyclophosphamide arm patients and about 72% of the mycophenolate patients experience an improvement in their forced vital capacity over this 2-year study. Next slide, please. And then we looked at other outcomes too. So one of the important outcomes, and another thing that's really important in patients with scleroderma, is their skin involvement. And so we measure skin involvement using something called the Modified Rodman Skin Score, MRSS. And this is an assessment that physicians do, and they look at 17 different parts of the body in a patient with scleroderma, and they measure the extent of skin thickness, and then they add up the scores. So a high score indicates more extensive skin disease, and a lower score indicates better skin disease. So you can see that in both groups, it started off pretty high, but then over the course of 24 months, it significantly went down, and going down indicates improvement. And again, those stars that appear there indicate a significant improvement from baseline. So it seemed as if both of these drugs actually had improvements not only in the lung function, but also in the skin disease. Next slide, please. We also looked at their shortness of breath. And one way to measure shortness of breath is something called the St. George's Respiratory Questionnaire. And this is a questionnaire that patients complete, and it basically asks them questions about how they're feeling in terms of their breathing, what they can do now, what they couldn't do before, and then we look at the change over time. And so a high score indicates worsening shortness of breath, and a lower score indicates better. So you can see here, both of the groups actually had a decline in their scores, and that indicates an overall improvement in their breathing with these treatments. Next slide, please. So to summarize, we have these two options available: the cyclophosphamide, which again didn't lead to a sustained improvement in lung function because it was only given for 1 year, and we worry about the long-term safety if we give it longer. And then we have mycophenolate that seemed to work just as well as the cyclophosphamide, but is probably safer to take long-term. But another option I wanted to speak with you about today is stem cell transplantation. And part of the reason I included this in this talk is because this is something that a lot of patients come to me and they ask me about. And it's important to understand the process, and also more importantly, to understand what patients might benefit from this approach. So most of the time when we do stem cell transplantation for a condition such as scleroderma, we do something called autologous stem cell transplantation. So this is where the cells that are being transplanted into your body actually come from yourself. They don't come from another person. So in order to do this process, the first thing that is done is patients are given a medication called G-CSF, and this medication stimulates the bone marrow to start producing a ton of white blood cells. And the next part there. And so the next step is to do something called leukapheresis. And this is kind of a fancy term for taking out all those white blood cells from the body, because then we actually put them into a machine and select out only those cells that have a marker on it called CD34. And we think that these cells are the best cells to reintroduce back into the body to kind of reset the immune system. Next slide, please.
And Elizabeth, I might mention this different than what patients may see advertised for stem cell therapies for different lung disease. This is evidence-based. The treatment you're talking about is evidence-based treatment that's been used for many years for the treatment of hematopoietic leukemia and other abnormalities, in contrast to therapies that are being advocated that are not FDA approved and have limited evidence. So to distinguish the two, I think, is really important for the audience.
Yeah, absolutely. So, and I think the word stem cell gets kind of thrown around a lot, and there are some, other countries that offer different types of stem cell transplant protocols. But this is another way you could call it, as sort of a bone marrow transplant. But it's a protocol that's often used to treat cancers, and now is used in a limited number of patients with scleroderma. But thank you so much for pointing that out. So the next step in the process is actually to then condition the patient. So they receive chemotherapy, usually higher dosages of the cyclophosphamide. They may also even receive radiation, and this is done to ablate or really suppress the immune system, so that the next step, just click the next one, then those CD34 positive cells are reintroduced. And that is what we think kind of resets the immune system so that it can function more normally. Next slide, please. So what is the evidence for this approach? Well, there was a study that was done and published in 2014 that was done in Europe, and it was called the ASTA study. And in this study, 79 patients were randomized to getting the transplant, while 77 were randomized to just getting cyclophosphamide. And the majority of patients in this study actually had interstitial lung disease. And what they found was that the patients who got the stem cell transplant had an increase in their forced vital capacity compared with the cyclophosphamide arm patients. And in addition, the mortality rates, the death rates, were slightly lower in the transplant group compared to the cyclophosphamide group. And in this figure here, this looks at overall survival in these patients. So this is a graph that we look at a lot in medicine. It's called a Kaplan-Meier curve. And what you can see is on that y-axis, the vertical axis, is the percent of patients who are surviving. So as the curves go down, that means that patients are unfortunately dying. And you can see in the transplant arm, in the very early stages, so in the first year, actually more patients died in the transplant arm. And we think that this is because it is a risky procedure. When you do suppress the immune system to such a degree, patients are at heightened risk for getting infections. But then long term, actually, the transplant patients have better survival. And so this is looking up to 10 years after the transplant. And you can see that if they survive that first year, they actually overall can do better than the patients who just received the cyclophosphamide. Next slide, please. So a follow-up to this study was a study that was done in the United States, and this was published last year, and this was called the Scott study. And in this patient, 36 patients were randomized to transplantation, and 39 were randomized to cyclophosphamide. So it was a slightly smaller study, but virtually all patients in the study had interstitial lung disease. And they found that there was an increased risk of respiratory failure in those who received cyclophosphamide compared to those who received transplant. And in addition, there was a much higher risk of death in the cyclophosphamide arm long-term compared with the transplant arm. And if we pull up the next figure here, again, this is the similar curve that I showed you before, the Kaplan-Meier curve, looking at the patients who are surviving. And in this one, there's less of a survival disadvantage early on. So it was actually only 3% of patients in the transplant arm died in that first year compared to 10% in the other study. And long term, there's overall better survival. Next slide, please. So what I would really like to message to send about this approach, though, is that this is, a reasonable option for patients with a specific type of scleroderma lung disease. And it's really patients who are having rapidly progressive disease that are seen at very experienced transplant centers. So in these studies, it included patients who had diffuse skin disease from their scleroderma. They had organ involvement. Most of them had interstitial lung disease, and most of them had early disease, so less than 3 years. And I mention this because I think it's really important if you want to learn whether transplant is an option for you to see whether you meet these criteria. And the reason we use this is because it's a risky procedure. In anything we do in medicine, we're always weighing the risk and benefits. And if you're a patient who has very long-standing scleroderma, you've had it for 20 years, you don't have significant lung disease or skin disease, the procedure actually may not benefit you, but you're still going to get all the risks in doing it in terms of the risk of the immune suppression. So I think it's really a good idea to talk with your doctor to see if you're the right candidate for this, because it's really only an option for specific patients with scleroderma at this point in time. Next slide, please. So I'm going to conclude the talk and actually speak about some of the really exciting research that's been going on in scleroderma-ILD, particularly in the last year. And the first medicine I'm going to talk about is Nintedanib, and this medication was recently approved for the treatment of ILD in patients with scleroderma. And Nintedanib works in a slightly different way than some of the other therapies that we use in scleroderma. And it's what we call a tyrosine kinase inhibitor. And it's a medication that acts on a part of the immune system that affects fibrosis or the scarring. So some of the other therapies that we talked about, like the cyclophosphamide and the mycophenolate, they kind of more broadly suppress the immune system, but nintedanib is something that actually acts to break up the fibrosis. And so that's why it was actually quite appealing for looking at this medication for the treatment of SSc-ILD. Next slide, please. So in the study that was recently published last May, it was looking at patients who either received nintedanib or placebo. And it was a study that was done where they looked at the primary endpoint at 52 weeks, so at 1 year. And you can see the end here represents the number of patients. So this was a very large study. So 288 patients got the nintedanib and 288 patients got the placebo. So this was actually the largest clinical trial that has ever been done for patients with SSc-ILD. Next slide, please. And it included patients very similar to the previous scleroderma lung studies. They were adult patients. They had to have a disease duration of less than 7 years, and they had to have at least 10% of fibrosis of ILD based on their CT scan. And they also had to meet certain criteria in terms of their pulmonary function testing. Next slide, please. Importantly, patients were permitted in this study to take mycophenolate or methotrexate. So if patients were taking these medicines and they'd been on a stable dose for the last 6 months, they were actually allowed to continue on these medications during the study. So I think it's really important to keep this in mind as we're interpreting the results of the study, because in fact, about half of the patients in the study were taking background mycophenolate. So even some of the patients that were in the placebo arm, they were actually getting therapy during the study with mycophenolate. Next slide, please. And they looked at the annual rate of decline in the forced vital capacity over 52 weeks, but they also looked at some key secondary endpoints. So they looked at the change in the skin score, the MRSS that we talked about before, and they also looked at the change in shortness of breath using that St. George's respiratory questionnaire that we also discussed that for. Next slide, please. And you can see in terms of the primary endpoint, this was the adjusted annual rate of decline in the FVC. And in the placebo arm, which is on the right, you can see that there was an increased rate of decline in the FVC compared with the nintedanib group. You click the next part there, it actually shows you the difference. It was a relative reduction of 44%. And in addition, the p-value, which is how we measure whether something is statistically significant, was 0.04, which again indicates that this was actually a significant treatment effect, that nintedanib actually slowed the rate of decline of FVC relative to placebo. Next slide, please. And this is another way to visualize the changes that occurred. So this was the absolute change from baseline in the FVC over 52 weeks. And the dark blue line is the nintedanib group, and the light blue line are the placebo patients. And you can see that over the course of the 1-year study, really starting at week 12, these lines start to diverge. And again, there's just a further decline in the patients who got placebo compared with the patients who got nintedanib. And this persisted all the way out to 1 year and seemed to actually just get bigger with time. Next slide, please. But I mentioned to you, however, that some of the patients were taking the mycophenolate at baseline. So the authors of this study did a separate analysis where they looked just at the patients taking mycophenolate at baseline, so what you see on the left there on the graph, and then those not taking mycophenolate at baseline. So it still appeared that when patients were taking mycophenolate at baseline, there was still a treatment effect of getting the nintedanib, meaning that the nintedanib group still performed better than placebo even when a patient was taking mycophenolate. However, if they were not taking mycophenolate at baseline, actually there was an even bigger treatment effect, and that the medication seemed to have a greater impact on those that were not taking mycophenolate at baseline. If you want to click the next part, it will show you the difference actually. Perfect, and you can click one more time. Great. So you can see that the difference between the two groups was about 26.3 milliliters per year when they were on mycophenolate at baseline. But if they weren't, it was actually much higher, 55.4 milliliters per year. And I know this slide can be a little bit confusing. I don't know if Greg, you have any comments about it as well.
Well, I guess as I was sitting here and thinking about the data again, what it suggests to me is that there are multiple ways in which we could impact the fibrotic process in patients with scleroderma, given that nintedanib and mycophenolate have different mechanisms of action. And so I think that's a subtle comment, but really important, because it might translate to other diseases, that there are multiple ways we can impact the disease state, and it's encouraging that we have other ways to help patients moving forward, and perhaps with combination of therapy as suggested by these data, with and without mycophenolate. But we have to begin to look in each specific disease moving forward. And Adeji, I don't know if you have any additional comments as well.
Yeah, I completely agree. I think in my mind, it just underscores the fact that these two therapies are not mutually exclusive. And I kind of view them as, or view the Nintedanib as an additional lifeline for patients, if you may use that term, which doesn't necessarily mean you're taking away what they have from them before, but adding an additional therapy with value on top of what they have.
And the other
that's really helpful
too, Elizabeth, is the importance of these well-designed clinical studies, that we really want to be careful because of the toxicities that you've mentioned, specifically with medications like cyclophosphamide, that we did show a benefit, but there is a risk associated with each and every treatment. So making sure that we have the best medicines with the least amount of side effects and the appropriate patient was a comment that you made that was really, really appropriate, whether it's to bone marrow transplant or any other therapy that we utilize.
Yeah, absolutely. And I think, it's important to keep in mind in our other rheumatic diseases. So when we treat patients who have, let's say, rheumatoid arthritis or lupus, we often use combination therapies in these patients, because these are very complex diseases that affect the immune system. So I think in scleroderma, we're moving in that direction where we're beginning to realize that this is a very complex disease, and the treatments that may be required may have to work on different aspects of the immune system, and they actually may work synergistically. So I was really excited about these data as well. You can go to the next part, please. Next slide.
Okay.
Perfect. And so I also mentioned that one of the secondary endpoints from the study was looking at the skin score changes, the MRSS. And both groups actually decreased, but there was no difference. Again, this was a study that was primarily designed to look at the effects of nintedanib on the lung disease, and they did not find that it had a significant effect on skin disease and scleroderma. Next slide, please. And then they also looked at the St. George's Respiratory Questionnaire. And again, this is a self-report measure of shortness of breath and daily function. And there also wasn't a significant difference between patients randomized to nintedanib versus placebo in terms of this outcome. Next slide, please. I do think it's important to go through some of the most frequently reported AEs. So these are adverse effects that were appreciated in the study. And the two that I wanted to point out, if you just click 2 times. So the first one is the diarrhea. So about 75% of patients in the study experienced diarrhea who were randomized to nintedanib versus 31% to placebo. And about 12% developed weight loss compared to 4% in placebo. So I think that, as we're starting to use this medication, it's important to keep in mind that this could be a side effect that could come up. But there are ways of dealing with this side effect, including reducing the dose of the medication. And importantly, when patients develop this side effect, it didn't seem to affect the rate of them staying on the drug. So it didn't cause them to actually stop taking the drug during the study. But I think this is important as a patient to just keep in mind that this is a side effect that can occur. Next slide, please. So just to summarize this study, because again, this is a really important study that came out this past year in scleroderma, it did meet the primary endpoint, meaning that there was a slower decline in lung function in the nintedanib group compared with placebo. And it appeared that patients on MMF had baseline had a slower decline in the FCC, even though this was not a statistically significant difference, but the combination group seemed to do the best. There was no effect on their skin disease or their self-reported shortness of breath, and the medication appears safe, although diarrhea and weight loss occurred more often in the nintedanib group. Next slide, please. So I wanted to conclude with just going through some of the experimental therapies that are available now for SSc-ILD. And one of them is a medication called tocilizumab. And this is a biological medication that targets IL-6. And it's already approved for the treatment of rheumatoid arthritis and some other connective tissue diseases. And there was a phase 2 trial that was done specifically in patients with scleroderma. And it was a study that was designed to look at how this medication affected their skin disease. And what they found actually was during the course of this phase 2 trial that fewer patients in the tocilizumab arm had a decline in their forced vital capacity. So this was kind of like an unexpected finding, but they thought, well, maybe this medication could be working for lung disease. A phase 3 trial was done, also looking at the tocilizumab versus placebo for the skin disease. And unfortunately, it did not meet the primary endpoint, meaning there was no significant effect on the skin disease. But if you go to the next slide, I just wanted to show you the figure looking at the percent change in the FVC. So this is a little bit complicated of a graph, but basically it's looking at the percentage of patients who experience either an improvement in their FVC or worsening. So if you see on the horizontal axis, the x-axis, if the FVC is going down, that indicates worsening. And if it's going up, then it indicates improvement. And the red line there is tocilizumab. So you can see that more patients are actually experiencing an improvement in their FVC, and more patients in placebo are actually experiencing worsening. And so tocilizumab may be an option for treating lung disease and scleroderma, although I think more research is needed. And it's important to note that this drug did not have a significant effect on skin disease, so this would really be an option just for targeting the lung disease in these patients.
It furthers the complexity of the disease, perhaps another intervention.
Exactly. And my hope in doing research in this area is that we can one day really personalize the care of patients with this condition, where we may be able to look at other things like blood tests and be able to tell a patient, well, you might do better with nintedanib, or you may do better with tocilizumab. I think that the more options we have, we're able to really utilize precision medicine and personalize the care that will hopefully lead to better outcomes. The final one I wanted to talk about was a medication called rituximab. And this is a medication that targets the B cells, so a specific part of the immune system. And part of the rationale for looking at this medication in scleroderma is that on lung biopsies of patients who have interstitial lung disease with scleroderma, there seems to be a high level of B cells in the lungs. So it kind of made sense from a pathological standpoint to try a medication such as rituximab. And there's been some open label trials, case reports, and a very small controlled trial that have looked at rituximab specifically in patients with SSc-ILD, and they're not responding to other medications. So they may have tried mycophenolate but didn't do well on it. And it seems based on these small studies that rituximab can slow the decline in lung function. There is a clinical trial underway right now in the UK, and it's comparing cyclophosphamide to Rituxan in patients who have connective tissue disease-related ILD, and many of these patients actually have scleroderma. So that study will actually be really revealing to see sort of what is the safety and efficacy of this medication in comparison to cyclophosphamide. But in my own clinical practice, I use rituximab quite a lot in patients who do not respond to traditional therapies like mycophenolate, and it also seems to work pretty well for their skin disease. Next slide, please. So to summarize, I think it's important to keep in mind that ILD is the leading cause of death in patients with scleroderma. And I personally feel that because of this, treatment should be initiated very promptly in these patients, because once they have progression of their interstitial lung disease, it's very hard to reverse this process. And the options that we now have available for these patients include mycophenolate, cyclophosphamide. We have the hematopoietic stem cell transplant just for select patients with scleroderma. And then we have an exciting new option for patients now, Nintedanib. And then finally, there's some experimental options here. So the rituximab, which I, again, often use in patients that are not responding to other therapies. And then potentially tocilizumab, although we need more research on this in the future. And I think that's the end of my slides. And I just really wanted to thank you for all of your attention and the insights from the other speakers. And I think at the end, there'll be an opportunity for questions. So I encourage you to write in any questions you may have. But thank you so much.
Thank you, Elizabeth. That was fabulous. It really is wonderful to see the science progressing directly into impacting patients and the care that we provide. So thank you for reviewing a pretty complex topic in a short period of time.
Thank you so much.
And now I'd like to bring back Deji back, and he's going to discuss a slightly different area, but I think important to this group, progressive fibrosing interstitial lung diseases and recent evidence that's available.
Thank you, Greg, and thank you to the Pulmonary Fibrosis Foundation for the invitation and for organizing this series of educational webinars. It's really exciting to be here to discuss how we conceptualize the progressive forms of pulmonary fibrosis and the potential impact of this classification on treatment. I have the unique privilege of taking us briefly through two recent and important clinical trials for antifibrotic therapy in PF-ILD. These are my disclosures as depicted on the screen. So before we launch into the clinical trials, I'd like to take a moment to remind us of what these important concepts of progressive fibrosing interstitial lung disease really is. The term pulmonary fibrosis often connotes interstitial lung disease. That's a disease in which there is an architectural distortion of the lung tissue with deposition of scar tissue within the lungs themselves. This frequently leads to shortness of breath and low oxygen levels. Now, there are very many causes of interstitial lung disease, and some of these include ILD from connective tissue disorders, commonly called autoimmune diseases, such as Scleroderma-ILD, which Dr. Volkmann nicely discussed moments ago. Others include exposure to environmental antigens called hypersensitivity pneumonitis. And then there are those ILDs that have genetic underpinnings, and also those in which the cause is unknown. The most common of these is idiopathic pulmonary fibrosis, IPF. Now, a subset of these fibrotic ILDs will develop self-sustaining fibrosis, in which the pulmonary fibrosis worsens, and these are the ones typically called the progressive fibrosing ILDs. Unfortunately, this worsened fibrosis is accompanied by worsened lung function and poor survival rates. If you can advance a little bit. So as you can see on the graphic on the bottom right hand of the screen, those subjects who had progressive fibrosing interstitial lung disease over time had a more severe mortality pattern and poor survival as depicted on the screen. So now with this understanding, we'll take a look at the first PF-ILD study, which we'll be discussing today. This was a study published in the Lancet Respiratory Medicine in 2019, and it focused on understanding the efficacy and safety of the antifibrotic therapy pirfenidone amongst those subjects with unclassifiable PF-ILD. That's a form of PF-ILD in which the fibrosis follows no distinct radiographic pattern. Now, this was a phase 2 clinical trial. It was across 70 centers in Asia, Europe, Australia, and North America. And it enrolled subjects with unclassifiable PF-ILD, those subjects who had fibrosis that exceeded 10% of their lung volume on a recent chest high-resolution CT scan. For these subjects also, the forced vital capacity and the diffusing capacity of the lungs, FVC and BLC respectively, were to be no lower than 45% and 30% respectively of the normal predicted values. As you can see on the left flow chart, for the study of 303 eligible subjects that were assessed, 253 were randomly assigned to either pirfenidone or placebo arm. Now, as these subjects with unclassifiable PF-ILD may have been diagnosed with autoimmune ILDs or have received mycophenolate for immunosuppressive therapy, randomization had to account for this as well. Ultimately, this resulted in 127 assigned to the pirfenidone arm and 126 assigned to the placebo arm. For this study, the primary endpoint was the change in the forced vital capacity measured in milliliters by home spirometry and assessed over 24 weeks. The authors also chose to evaluate multiple secondary endpoints. So they chose metrics such as the FVC change using the clinic spirometry, the proportion in whom categorical FVC change exceeded 5% or 10%. They also looked at the change in DLCO as well as the 6-minute walk distance and standardized scoring systems which assessed the severity of shortness of breath and cough. For the study, the efficacy of pirfenidone was analyzed in the intention to treat population at the bottom left-hand side of the screen at the end of the flow chart there. And as can be seen from table 1, the randomization was quite effective. So if we advance a couple of slides, please. Yeah, there we go. So as can be seen from table 1 here, the randomization was quite effective and resulted in a very similar distribution of subjects across the various subgroups of age, gender, race, the body mass index, and various lung function metrics. Similarly, the population of subjects who had interstitial pneumonia and autoimmune features, called IPAF, and those that were treated with mycophenolates, as well as those who were ultimately diagnosed as having unclassifiable PF-ILD, were all similar across both groups. Next slide, please. So when we move on to the results of the study, a notable finding was that the daily home spirometry measured the FVC values. Here, these varied substantially within each patient, and this wasn't detected early as repeated daily measurements are typically required for activation of quality control measures with home spirometry. These quality control measures typically help to safeguard against erroneous measurements. Now, we see from figure 2 on the right-hand side of the screen, this illustrates this observation quite well, where the median change in FVC for the pirfenidone and placebo arms were -88 mils and -157 mils respectively. However, we note at the top of the figure there that there were values that exceeded 16,000 mils and 32,000 mils respectively. These values typically are not physiologically possible. As such, the primary endpoint could not be analyzed successfully in this trial. However, the a priori decision to include FVC values from spirometry performed at the study enrollment site as a secondary endpoint proved to be a brilliant move for this study, as this was less subject to the variation and calibration errors which we previously noted. As you can see from table 2, the decline in FVC was much lower in the pirfenidone arm compared to the placebo arm, both when assessing the mean values and the median values. Similarly, when compared to placebo, fewer patients receiving pirfenidone had a 5% decline in FVC. And the same was observed too with a 10% decline in FVC, which typically is considered clinically meaningful. It was also noted that the treatment effect for the change in DLCO and the 6-minute walk distance favored the use of pirfenidone. Now, as clinicians, when we think about therapy for a disease, we like to see the big picture, the totality of the effect, essentially seeing the forest for the trees. But sometimes the trees themselves could be insightful. Thus, the authors had pre-specified certain subgroups for exploratory analysis in this clinical trial. So figure 3 at the top right-hand side of your screen is what we call a forest plot, in which the solid vertical line represents no change in FVC, while the tiny black squares and the accompanying horizontal black lines represents the change in FVC at 24 weeks with the associated confidence intervals. Typically, larger subgroups have narrow confidence intervals, while smaller subgroups have wider confidence intervals. When we think about the point estimates of the effect of pirfenidone across subgroups, the tiny black squares, there was generally a treatment benefit regardless of age, sex, or lung function. Most importantly, in the overall cohort, we observe a clear benefit of pirfenidone with a mean difference of 95 mils when compared to placebo. Of note in this study, the incidence of gastrointestinal disorders, fatigue, and rash were more common with the use of pirfenidone. So overall, the authors concluded that patients with unclassifiable PF-ILD could benefit from pirfenidone treatment. Now we'll switch gears to a separate study that assessed the efficacy of another antifibrotic medication in PF-ILD, and that's nintedanib. Nintedanib is a tyrosine kinase inhibitor that has been previously shown to be of value and effective in patients with idiopathic pulmonary fibrosis, IPF. This PF-ILD study for progressive fibrosis and interstitial lung diseases evaluating nintedanib was published in the New England Journal. It was a phase 3 clinical trial conducted in 15 countries, again with very similar enrollment criteria, which typically were fibrosis that exceeded 10% of their lung volume on chest high-resolution CT scans, having evidence of recent ILD progression, and the FVC should be of 45% or greater, as well as the DLCO should be within the range of 30 to 80%. On the left-hand side of the screen, the flow chart there depicts the enrollment status. So of over 1,000 patients assessed for eligibility, 663 of them underwent randomization, which was stratified by the pattern of fibrosis to ensure an equal distribution of those with a UIP pattern, that's a usual interstitial pneumonia pattern, and other fibrotic patterns in both study arms as well. The primary endpoint for this study was the annual rate of FVC decline assessed over a 52-week period. The main secondary endpoints included the change in the total score for a metric that measures the health-related quality of life, called the King's Brief Interstitial Lung Disease Questionnaire. Also, the time until first ILD exacerbation and the time to death were assessed over the 52-week period. For this study also, the effects or the efficacy of nintedanib was analyzed in the intention to treat population. And as can be seen from table 1, the randomization was quite effective with very similar distribution of the subjects across the various subgroups of sex, age, race, smoking status, fibrotic pattern, proportion with recent disease progression, and even the lung function metrics. It was pretty good randomization. Perhaps as we move to the next slide, perhaps the most striking finding of this study was the primary endpoint for efficacy as observed in table 2. In the overall population, as well as in the subgroups stratified by the pattern of fibrosis, the annual rate of FVC decline was lower with nintedanib, with an absolute difference of 107 mils, illustrating that patients who received nintedanib had a slower progression of interstitial lung disease than those who received placebo. Interestingly, the magnitude of this benefit is similar to that which has been observed among patients with IPF in previous trials. And this fact may reflect some similarities between the PF-ILD population and the IPF cohorts, and possibly even suggest a final common pathway to fibrosis. All the main secondary endpoints, the K-BILD score, the percentage with acute ILD exacerbation or death, and the percent all-cause mortality were not met. Well, this isn't surprising given the study design, the duration of follow-up, and even the insight you can glean from prior clinical trials of nintedanib as well. However, when we take a closer look at the differences in FVC decline on spirometry at the study intervals, if we advance the slide just a little bit, we'll readily notice that the two treatment arms separated pretty well early and diverged at all time points after the 6 weeks period, all through the 52-week period, similar to prior clinical trials of nintedanib in pulmonary fibrosis, also similar to what Dr. Volkmann just showed us for the census trial for Scleroderma-ILD patients. Again, assessing our forest plot, we observe on the next, we observe here a clear benefit of nintedanib in patients with a usual interstitial pneumonia pattern of fibrosis and in other fibrotic forms of PF-ILD as well. And here the overall mean difference is seen of 107 mils when nintedanib and is compared to placebo. Also of note in this study, the incidence of gastrointestinal disorders, most notably diarrhea, nausea, vomiting, and liver function test abnormalities, were more common with the use of nintedanib, similar to the adverse event profile outlined earlier by Dr. Volkmann with nintedanib use. Overall, the authors concluded that patients with unclassifiable PF-ILD who received nintedanib had a slower rate of ILD progression than those who received placebo, independent of the fibrotic pattern on high-resolution CT. Now, these two trials enrolled carefully selected patients with PF-ILD across multiple countries and determined that the therapeutic efficacy with the use of antifibrotic therapy was substantial over the course of 24 weeks and 52 weeks respectively, with a tolerable side effect profile. But how about in the real world setting? Well, now we switch to the Pulmonary Fibrosis Foundation Registry. This is a unique registry that provides a robust US-based data set with very carefully logged data accrued from patients with pulmonary fibrosis, followed at over 60 sites across the United States. Now, while many patients with different forms of pulmonary fibrosis are enrolled in the registry, the majority of them do have progressive fibrosing ILD, with many of them on antifibrotic therapy. Now, this registry has vast amounts of clinical and biospecimen data, and these have all been captured longitudinally over several years, permitting investigators to study different aspects of pulmonary fibrosis over time. Overall, the primary purpose of all this is to help understand and improve our current knowledge of pulmonary fibrosis with the hope that someday we'll find a cure for this devastating disease. With that, I would like to turn it back to Dr. Cosgrove for the rest of the presentation.
Thank you very much. That was a very detailed description of two complex studies in a short period of time. And I might summarize that we're now seeing that proven treatments for those with patients with idiopathic pulmonary fibrosis may have benefits. And your comment was should be underscored that there may be shared mechanisms that impact the fibrotic process throughout different diseases that we can intervene and treat patients in the future with different forms of pulmonary fibrosis. And I might say it's important that we don't just treat fibrosis and forget about the underlying disease. And I think Elizabeth's talk demonstrated how important it is that different diseases may respond to different therapies. And so it's still very important to have an accurate diagnosis for the cause of your lung fibrosis. Then we can treat that, and I think just as importantly, treat the associated comorbidities, because those with rheumatoid arthritis need advanced care for the rheumatologic aspects of the disease that perhaps those with IPF do not, and vice versa. Scleroderma is a different disease. So as pulmonologist and rheumatologist, we want to treat our diseases. I think it's important to step back and focus on treating the entire patient. And I know that is the way in which both of you treat your patients, but it's important to recognize and at least comment upon. And this speaks to one of the questions that we had, and so I thought I would bring it up in the short period of time we have left. Well, what if one of the questions was, I've been trying to access a clinical study, but I can't necessarily get the sponsor to call me back or the site. And so this is a lot of work that people at the foundation have done to try to assist with that. And so if you go to the foundation webpage, and I'll pull it up here and enlarge it, and then you go to Life with PF and Clinical Trials Education, you can, number one, learn more about clinical studies, and it describes the phase 1 and phase 2 that were alluded to. And then you can actually go in and for those of you who haven't seen it, you can actually put in your zip code. I'm going to put my office right here in Denver, and then I'll disclose I'm not -1, but I did turn 51 and I'm a male, and I'll assume I have pulmonary fibrosis, and then we want to search all trials around me. And so these are all individual trials that you could access moving forward. And if you click on the specific study, this answers some of the questions. You can identify sites around here. Closest would be where I work. But if you're having trouble getting in contact with individuals, you can contact not only the sponsor, there is a telephone number. And so it is a way in which patients that are motivated, that want to learn more about the studies or sites that are close to you, can access clinical trials. And different studies actually have the coordinator's name associated with it. So for that one question, and a very motivated individual who wants to give back to the community and enroll in a study, this might help you. And oftentimes at the foundation, I think this talk suggests there's a lot going on in the field. And I think that's really important for patients to understand that there is so much work going behind the scenes, and we wanted to really represent that in an important way. And so again, a lot of work and support throughout the community. This is a list of all the studies that are being done in the pulmonary fibrosis field, and they're broken down by those that are studying idiopathic pulmonary fibrosis. So I just want you to look at the length of this list. And it's organized by phase 1, phase 2 in terms of the status where they're going. So this is a tremendous amount of work. If you're interested in a specific study, you can click on that study and it'll bring up the information. So hopefully this provides an easy way for patients, their family members, to understand what's going on in the field. You can actually look at those that are specifically looking at different diseases like IPF or hypersensitivity, rheumatoid arthritis, systemic sclerosis. So for that one question that we had that was dealing with how do you get past all the information and really have it apply to you, this could be helpful for you. And I'm just going to scroll down again, a massive amount of effort trying to help patients with interstitial lung disease of various different causes. So it's an exciting time in the space, and I'd like to suggest this demonstrates what I think is a lot of hope for our future in caring for patients with pulmonary fibrosis. We now have 2 approved drugs in IPF, 1 in scleroderma, and several that are going under review. So it is a really good time. We need it to happen as quickly as possible, and I understand that. And what I will end on is Elizabeth mentioned that perhaps we should have therapies that are designed specifically for you, not the generic you. And so individuals at UVA and at Cornell, Drs. Imre Noth and Drs. Fernando Martinez designed this study, and I wanted to demonstrate it because it's a wonderful collaboration that's completely a result of a lot of individuals working together. So it's the precision study. So we're going to hopefully try to accomplish what Dr. Volkmann had alluded to. By using patients in the registry that donated their blood, we're going to perform a clinical study in which specific markers in patients will help them enroll into the study. And then moving forward, we can understand if a specific therapy for individuals with IPF helps them. And importantly, we do not provide that medication for individuals in which it wouldn't help, or perhaps it would harm them. And so this is just there's more information that you can provide, and certainly it's on that pipeline list, but I think it's the future of care in pulmonary fibrosis, that by understanding the disease and then directly identifying ways in which we can help specific patients move forward. So it speaks to Elizabeth's comment. We want to reduce the risk, maximize the benefit for each and every patient. And so I'd like to thank Dr. Martinez, Dr. Noth for spearheading this, but as you see, it is the result of working with the National Institutes of Health, the Pulmonary Fibrosis Foundation, a partner in the community and philanthropic supporter, Three Lakes Partners, as well as the 2 lead academic institutions and our partner in Zambon. So it's a great example of everyone working together, and it would not have happened without the time and of patients to volunteer to participate in the registry. And so I'll finish here. I know we're just a few minutes over, and I might take the prerogative to answer these questions in the interest of time, but one question was, is there anything new regarding cough prevention? And I don't think we're quite there yet. I might refer you back. We did a cough webinar about 2 months ago. If you hadn't seen it, we did a nice thorough review of cough in pulmonary fibrosis. There are trials that are emerging specifically to address cough right now. So I think that's an important prevention is probably a little challenging because we need to understand cough much more thoroughly, but treating cough we are investigating. The next question, we talked about the LICAT protein, which is a really interesting mitochondrial protein that appears to be upregulated in patients with pulmonary fibrosis, and it appears in models of lung fibrosis that it may be involved in the fibrotic process. It's still early. We still need more information and science, and clinical trials hopefully will be performed, as this is an important potential mediator, but it certainly is not in the realm of clinical care. And that last question, hopefully I addressed moving forward, and I'll just check to see if Lindsay went ahead and gave me a I don't see any specific new questions, so I know we're a little bit over. So what I may do is, number one, just thank Dr. Volkmann and Deji moving forward, and remind you next in March 4th of 2020, we're going to have environmental induced lung disease, and an expert, Dr. Murdu Galati, discuss that, as well as myself and Dr. Amy Case will participate. So I'd like to thank everyone, thank our presenters, wonderful discussion today, and appreciate your attention, and sorry for being a few minutes over. So have a great rest of your day.
Thank you so much.
Thanks, Greg. Bye.
Take care.
Bye-bye.